in Ukraine, and this is our, I think, hope and fingers crossed for that. I'm very happy that Dr. Thomas Rappel agreed today to speak about his experience with B-lite. Why? Because I think he has been with us since the beginning of our journey with B-lite, and he could share his personal experience and practical usage tips and tricks about B-lite and lightweight implant experience. So I wish you nice webinar and let's enjoy. Thank you very much.
And one more little additional info. If you have any questions, I mean the audience, if you have any questions, you can always type them down in your chat, and I will read them after. Please don't use the microphone during the seminar, just type the questions in the chat and we will read them after. And be active with the questions, because there is an actual chance to get the practical knowledge and to get the practical tips and tricks. Ще раз на всяк випадок українською. Якщо у вас є запитання стосовно теми семінару, стосовно того, що говорить Томас Рапел або Денис Олександрович, будь ласка, пишіть ваші запитання в чаті, використовуйте чат для того, щоб написати запитання. Я буду їх потім зачитувати, і це можливість отримати практичні поради та практичні ідеї для вашої практики. So, without further ado, let's start, and I pass the word to Thomas.
Okay, so thank you very much for the invitation, and I'm really honored and happy to be with you, because it's such a nice opportunity, even if it's online, and I hope things will get better in the future so we all can see each other in person. Due to this terrible situation you have, and we all feel with you. So as I've been introduced, I've worked with B-lite quite a long time, and the idea was making a small presentation in advance, so probably you know many things about that, but after this presentation we will get into details and discuss with our nice colleague here and with you, of course, and give you some honest answers to your burning questions. So let's start with the presentation. And actually, this whole presentation is about something about subjective and objective outcome and well-being after replacing breast implants by downgrading the implant weights. This has been a work what we did in the university, and where we wanted to demonstrate the advantages of the lightweight implants. As I'm a plastic surgeon based in Austria, also working for IMCAS as scientific board, so you're also invited to come to IMCAS if you can, to Paris or wherever you want. So let's go for the future correction surgery. These will be secondary cases, as you all know. And there I have the first point to mention. And the first point to mention is that we heard in the past around the capsule contraction rate around 15%, etc. But nowadays, it seems to me that this is much higher, because now the people, when we started to operate them, they're aging as we are aging, and now they got their problems. So I'm really curious about the upcoming papers about the capsule contraction incidence, because honestly speaking, I think there will be nowadays higher, but it could be also my impression. We don't have the data on that. You know the reasons for reversion surgery. It's a capsule contraction, malposition, implant rupture, tissue sagging, and of course the wish of the patient if they want to replace one implant to the other. So these are the capsule contraction rate as it has been reported, 3% after 2 years, and 8% after 3 years, and then 13% after 8 years. And then the German Society said that there is, in the reconstructive cases, of course, a much higher rate, up to 36%. And I think even for the reconstructive cases, this is something where we really love to have the B-lite implants, because as you will see afterwards, this is a place for a lightweight implant. And we are in the lucky situation in Austria that this is covered by the social insurance, but only if they exceed the weight of 400 cc. But this is something also to discuss. But nevertheless, most of the cases, in the reconstructive cases, we have around 400 cc and more for the implant volume. The approach, you know about the approaches, so I don't want to get into details. I personally take the inframammary approach if it's possible. Sometimes it's the periareolar incision. I personally don't like that much the axillary approach, but you know, this is also something where we can discuss, and this is something where you grew up with. And slightly the literature is in favor of the inframammary incision, but nevertheless, this is something which is not predictable and 100%. So if you're prone for the axillary approach and you love it, so why not? Because it's not that higher CC rate in these cases. The location, we can place the implant subglandular or submuscular. What I see now, if you look at the past, we're almost in a situation of fashion. The whole thing is like a pendulum. When I was young, everyone was doing the implant under the gland. Now I'm getting older. There's the new generation is coming. When I was young, it started with subglandular, then it was submuscular, and now again it comes back to 20 years ago, and everyone tries to get subglandular or even subfascial. So also this is something where I think it is not the right position to say I just do subglandular implants nowadays because it's more fashionable and everyone is talking about that and make some combined treatment with fat, etc. So I think it's almost depending on the patient situation if you put it under the gland or submuscular. About the subfascial implant placement, we also can discuss, because also if you look at the anatomical dissections, then you see that the subfascial implant position, the fascia is so thin. So in my opinion, and we also made some studies about that, that's not a big difference if you place it under the gland or under the fascia, but also something to discuss. Ways of contamination, you all know about that, the no touch technique. And what we also did is something about the preoperative antibiotic prophylaxis. This might be something interesting because there's a discrepancy between the antibiotic activity of commonly used antibiotics like cephalosporin and about the microorganism we found on the implant and then the capsule. Most of the times, these are coagulase negative Staphylococcus and propionibacteria. These are the main groups of those bacteria you can find. But if you look at the antibiogram, then you see that probably it's not the cephalosporin, which is the best one to choose. It might be the vancomycin, the glycopeptides, which are more interested in the preoperative antibiotic prophylaxis. So to summarize this, the conventional used cephalosporins alone for preoperative prophylaxis are, in our opinion, and as we said, we have a lot of capsule contraction to deal with in the university, so they're not the most suitable antibiotics to eliminate the organisms found to be associated with capsular contraction. And therefore, we also suggest to add some vancomycin in this regime, because with this, you cover the whole microorganism, which seem to be responsible for the capsule contraction. Prevention, the drains, something to discuss. Honestly, I say I never say never. So if I see during the operation, I have a higher bleeding, which occurs, then I put some drains in, but normally 99%, I don't do it because there are some papers which say they have a 5-time increased risk of infection. But if there's a need for drains, so why not? Because 5 times is not that that high that you should not place a drain in. Let's go to this. So we'll skip over it because we know about all the multifactorial risks of capsule contraction. So don't over decisive the buttons, change the gloves, and make a non-touch technique. I only use sizers in cases of severe asymmetry where I try to fix the problem. And again, it's also cohesive textured implants, which might be, and also Mesmo implants, which might be interesting for lowering the capsule contraction rate and also the polyurethane. So coming to the place, removing the implant and downgrading the weight by choosing lightweight implants. So you have to downgrade. The effect of gravity, you know all about that. So let's skip over this really nice and funny movie because you know it. And also if it gets to sports, and this is something where I find the implant is really interesting. I'm still the national doctor, the team doctor of the kickboxing team. So I'm coming from sports medicine and I have a lot to do with sports and sportive women. And that's why it's so interesting to work with an implant which is lighter. If you see the effects of the dynamic movement and weight, which has been in the full mass implant, and you see the gray curves here, and compared to the lightweight implant, so the curvatures are much flatter than the blue ones than compared with the gray ones. So you see in the motion, you have less stress on the lower pole on the breast and less movement excess. So this makes it also interesting, and especially for very sportive women. There's been a nice paper of Mickey Shefflan, who passed away 2 years ago. I think it was 2 or 1 year ago. Our time is passing quickly. I think it's 2 years now. And he clearly showed that in the asymmetry breast, that the heavier implants is sagging earlier and easier than the smaller implant. Also, the viscoelastic material and also the pressure on the tissue is, of course, interesting. The heavier the implant, the greater is the force of pressure on the soft tissue. And if you see compared to the normal weight implant, there's less pressure on the lower pole. We have only those 3 weak supporting structures, which are the corpus ligament, the rearing ligament, and the dermis. And you know 80% is type 1, and this is the high strain resistance. So you can imagine if you have pressure on your collagen, and type 1 collagen has 80% stretch, more than 80% stretch, then it's damaged. So this is also what you can see with all those stretch mark patients. 80% stretch means definitely a damage. Bringing the stability to an unstable environment, and these are the effects of the dynamic movement of the weight. So here you can see the full mass silicone implant and also the forces on the breast with the stretching and the weight compression, which is really nice to see in this animation with a normal full mass silicone implant. But if you remove this implant and switch to a lightweight implant, then you can clearly see that there's a reduction of the stretching of the dermal compartments and also of the weight compression. And effectively, it can say probably serving like an internal sports bra. What about the size of the implants? Now, if you look at Wonder Woman 50 years ago, and you think there has been a downsizing of the implant in all those years, then you see, no, there hasn't been any downsizing. So more or less, the women want to have at least a B, but normally C cup. And personally, I also prefer this. Honestly speaking, I hate the really big implants. And I said to my colleague when I put the last one with 600 cc in, please kill me the next time when I get for a 600 cc implants. I don't want this. Heavy implants, heavy problems. You know about the weight-related adverse events, the breast tissue atrophy, skin atrophy, ptosis, neck displacement, inframammary fold breakdown, traction rippling, and back pain. There's a close relationship between the breast to sac and the breast size. This is clearly demonstrated. And if it comes to reconstructive surgery, then you see this pressure on the lower poles of the implants. And this is the catastrophic cases where we have to deal with in all the kinds of reconstructive implant surgery. And therefore, we really go advertising for using lightweight implants because it clearly reduces the pressure on the lower pole. If you look at this, that not only that you have less pain of the vertebral spine, but we can see that, for example, a 665 implant is compared to the same weight like a 300 cc implant of a normal weight implant. If we go for a 435 weight implant, it has the same weight like the 200 cc implant. So there's really enormous difference and an enormous improvement for the patient's well-being. Up to 30% lighter implant than the traditional ones. What you find inside, it's microspheres, which are filled with inert air, so know about that. High purity borosilicate, biocompatible, chemical stable, cross strengths of 13 ATM, and filled with inert air. What is also interesting is that these microspheres have a reinforced shell, which means if you really tear this apart, it goes back to normal. So it won't go, if you have a rupture of the implant, it won't leak, it won't go anywhere, and it stays in the capsule, because it might happen even if you're going with the finger and pushing it too strong. Then was one of my first thoughts, what I did and what we can discuss afterwards, that I got with my finger through the capsule and into the implant. So you have to increase a little bit the size of the incision and bring it in quite smoothly. And probably it's also something where you see if you push it too hard, also with the normal implants, it's not the best way to squeeze and push and press everything into a small hole. What else? This is something where we have also to deal with is the silicone bleeding. And what we see in the B-lite implant compared to the silicone implant, in the long term, you have less silicone bleeding and less silicone gel. And might be something of interest if we go into the questions about the oil release, about the breast sickness syndrome. So we'll see if there's something in correlation, but you clearly see that there's less silicone oil what gets out. What's about the mammography? And you see it's more transparent than the normal implant, and even you can see also these microcalcifications are better visible under them in the radiography than the traditional silicone implant, because there's also a question almost, what about the implant? What about if I get the tumor? Can I do is it detectable? Yes, it is, and even better than in the normal implants. Now we come to the question, who is the perfect candidate? And honestly speaking, these are much higher priced implants. And it's almost a question about how can I sell these implants to my patients? And I think this is one of the, in my opinion, one of the most important answers or a question from the patients. And on the one hand is I almost say it's the well-educated, intelligent, smart businesswoman or the very sportive one. And in any case, if you say they're intelligent, smart, sportive, I say 90% will feel themselves that you're just talking with her and that you have the proper implant for those kind of patients. And if you sell this, like it has been, of course, the last revolution in plastic surgery, if it comes to implants, of course, the competitors from other companies say they are the number one of the innovative breast implants. So, but nevertheless, I think the B-lite one is really the number one because this changed a lot. And if you discuss this with the patients, if you say they have less risk that they on the vertebral spine, if you say they can do the sports as they used to do it before because they don't have a heavy implant in front, so then you will really succeed to sell them those implants. And I can say that I have professional tennis players. I have, of course, the kickboxers, and I have horseback riders, and I have golf sports, and all those are really, really very, very happy with those implants. And the one which is playing the tennis championships even get better in the ranking afterwards. So I don't know if it's just psychologically or if it's the implant. So I won't go that far. Okay, some results. Everyone who's working with breast surgery has good results, so we'll go over it. It has a natural touch because this is almost a question also for the patients who want to think which implants they want to have, because they almost say, okay, Motiva have a more natural touch, which is not true. And we can also discuss the differences between Motiva and also the B-lite, and why I switched completely to B-lite from the Motiva. In conclusion, in our follow-up study, what we did in implant replacement, we had a decrease of implant weight, which leads to a decrease of pounds of force of the vertebral spine. The postoperative pain reduction is also demonstrated. We have minimized skin under alteration in the lower pole of the breast after implant reconstruction. Also, if you replace the implant with the same size as it has been, for example, you replace due to the fact that they had some capsule contraction, whatever, or they don't like the shape, whatever, and you replace it with the same size, 400 to 400 on the volume, they will say they feel really an improvement of the vertebral spine because it's really that lighter in the front of the breast. We did the studies of 50 patients followed up for 3 years after removing the implant. So we have the inframammary fold approach, removing the implant, creating a new pocket over the old one if the capsule was normal and not contracted. So we sutured the capsule. Capsulectomy has been performed if necessary or according to the patient wishes, placing a new lighter implant with same or greater volume, mastopexy if needed, and the patient satisfaction rate was really high, over 90%. In those 3 years, we had no device-related adverse events. Of course, we had sometimes you have a hematoma or something like that, but nevertheless, we didn't have any displacement or even turnover, whatever. So we cannot work against gravity, but we can make life easier. And for that, I thank you for your interest and hope you got some more questions or some discussions, and hope I get you some ideas why I like to work with those implants. Thank you very much. Спасибо.
Thank you, Thomas, for your presentation.
Thank you.
But I have a question maybe about less than 400 cc. Did you use this implant for first augmentation? It's how predict of these implants if you use this less than 400 cc?
So I think 350 is most of the cases we're using. Most of the patients, like 80%, are around 300, 350. These are like 80%.
Did you use less than 300?
Less than 300, yes. This is especially Especially if there's very sportive women, then it's still the B-lite. So I never use the B-lite for less than 250. So around 250 and up, we'll use the
only for a sportive patient. It means what you are discussing with patient, which kind of sport did you use, or what you going to do with this implant?
No, it's normally so we have all those ranges of implants in the office.
It's your typical.
Yes, and so also different brands, because of course you have also people who want to have the Motiva implants or something different, and so you have all those range of implants. And as I'm really convinced about the B-lite implants, although as you know, they're from the pricing they're higher, then I try to convince them, or not to convince them, but I propose them the advantages of the B-lite implants, which means if they say, okay, it's 30% less of weight, this has most of the cases, this is clear for the patients that it's a clear advantage. And then I give them the choice. I say, okay, you have this opportunity if you go for an anatomical shaped or round shaped, whatever. But in any case, they can choose. Also, there's, I think, from the marketing in the internet, there's quite also a lot of patients which are interested in the implants, and even if they don't want to exceed over 300 cc, they're coming with the ideas that the implant is new, something special, and that's why they want to have it. So it's something like marketing, and every time if there's something new on the market, although now it's like 7 years or even more, it's not that new, which is also an advantage, because now we have to follow up a long time period and can say, okay, all those which we put in 7 years ago are quite stable. But nevertheless, they think it's new because now there's more the interest on the patients. And that's why that they, by themselves, decide to have a lighter weight implant than a normal one.
It means your patient tell you, I want to this new one, and you could tell me, okay, let's speak about this more information. Because I know this is very difficult to speak with patient, because she writes something about new, but you need to explain everything. And for me, it's I'm clear decided what I don't want to use B-lite for my patient. If they want to 300 or 350, I don't use it. But I don't like two very big breast implant, and for me it's very rare when I'm using a big implant. But only these cases I'm proposed to patient to use this B-lite, and for me interesting, especially how it work if we use in small amount, because we have 2 or 3 patients which implants did not sit on this place, which I'm expect, you know. Yes. When we did put in average weight implant, they sitting after some period of time. That's why I'm afraid of using these very light implants for my patient, because I'm expected to sit in right place this implant. And it's kind of predict for me to rare implants, but not predict this very light implants. And how do you manage all this situation? Could you explain patient what it could not sitting?
Sure. This is, in fact, it's a very, very interesting, good question, because we grew up, both of us and all the others around us, using the old style implants, if it's Mentor or was Allergan or whatever. And there we were taught that to put the implant a little bit higher, because they will, over time, will work on the lower pole of the breast. This is true for those implants, and even true especially for the very soft coated implants like the Motiva. And therefore,
Mesmo, it's maybe it's the same Mesmo, yes.
Mesmo is maybe I have the impression that Mesmo gets a little bit more fixed to the surface.
Little bit.
Yes, they're a little bit more fixed, and for me, as I try to put the implant right in place where I want to have it afterwards. So the Mesmo implant. Also, for if we have the polyurethane, it's the same. But if it's light, because it's 30% lighter, you don't have this pressure on the lower pole of the breast, which is something what you have to take in account when you're placing smaller implants in. They don't move, they stay there where they belong. Especially if you put them under the muscle, they won't migrate somewhere else. If it goes on the glands, even here, if you have a nice soft tissue around, a nice gland, then it won't work on the lower pole that much as it used to be with the other implants. That's true. So you should place it exactly on the place you want to have them on the long term.
I think it's very benefit for a reconstructive surgery, yes, because when you modeling new inframammary fold, it's completely, you can expect that this implant stay in the same position when you put it in operation room.
That's true. That's true. And it's very important to tell the colleagues, because if you don't do it and place it in that, then you might be not satisfied afterwards with the results.
And of course, it's very funny situation. What did you say about penetrate my finger to penetrate this implant? And it was for me big surprise. And we need to wait until we change implant, because it was for me a situation where the first time even have experienced to penetrate implant. And since this time, I'm using more incisors and very, very gently putting it inside, because it's kind of, I think for any people who want to start working this implant, we need to be careful with this implant, because it could be a surprise for you.
Oh,
and
yes.
it couldn't work again, because it's penetrate implant. It's not good.
That's true.
Yes, it's true.
Probably.
Situation.
Yes, sir.
I'm put it out, and when we waiting, I try to put another place.
Yeah.
And I put it in penetrate in another place, because I thought maybe it's some kind of problem with only this implant. Yes, but I decided what it could be easy to put it by finger. Now I change finger. I put an implant like this finger, because it could very, very rare. So, but did you use some kind of devices for putting this implant inside, or by hand?
Yes, normally we take the Keller funnel, because unfortunately, and this is almost something that we have to discuss with Polytech, they have this sac coming with the implant, but maybe I'm too stupid to use this, but it doesn't work in my hands. So the Keller funnel was really excellent, but of course it's extra cost what you have, but this device is really working quite well.
Do you think this device helped to low rate of capsular contraction or infection?
Probably, I think. Also, if you follow Mario Pelle, he says almost you're almost touching, and if you're controlling, then you have to put the finger.
Yes, if you rotate after after putting, you rotate them.
Yeah.
I think it's not very useful, but it's extra pain. Sometimes it work
Probably
Okay,
it helps. Probably it helps to minimize a little bit the incision because it goes in that easily with the Keller funnel. So this
it's
is
half of centimeter. It's not
Yeah,
a big deal.
yeah, you're right. You're right. So probably it's not worth the 300 euros you have to pay for the Keller funnel.
Yes, maybe. So, and one question about, did you say about you put an implant under fascia, under glandula and under fascia? Do you think this B-lite, it's good for this position? Because I can explain, but it's more, this implant more, this less light but more touchable, you know, this under glandula it could be more touchable in the final result.
You mean
That's why
it's harder on the touch, or
yes, and after under muscle it's more camouflage of this implant, and that's why I think this implant not very good candidate for putting under fascia or under glandula. What do you think about this? Did you have experience?
I think it's almost a question about the relation between the size of the breast and the implant. So if you have good coverage of the implant, then of course I think you can put it under the gland as well, because you have the soft touch of the breast over the implant, and it gives a stabilized situation of the whole situation, and I think it's quite convenient. And they also, what I experience is that it's a little bit harder from the touch in the beginning. After half a year or a year, it softens. So it's, I don't know, I don't understand the mechanism behind that, but the patients which come for control after 1 year, they don't complain that the touch is harder. So I didn't experience this on the long term. They have it after the operation, yes, they do. But on the long term, I haven't heard that they were unsatisfied with the feeling they have. Also, if in submuscular, no question, of course, but for the implants, no.
No. Okay. Did you use some lipofilling after this? Could you compare lipofilling under average implant or under B-lite? It's which of this implant more problem with lipofilling?
I don't think that there's a problem between implants and lipofilling, because lipofilling in my those
No, I mean lipofilling like after breast implantation, we use lipofilling for more
Yes.
camouflage of this.
Yes. Yes. I don't think that there's a difference.
No difference. It's the same like average implant like this.
Yes.
It depends on covering tissue of patient.
Exactly. Yes.
So
experienced.
did you, if you have that patient have a small amount of tissue, could you work with big implants, or you told them no, it's completely not?
Yes. I stopped doing it. Everyone has his own, takes his own teaches of all his mistakes, and I think putting big implants in a skinny patient, this is a mistake.
Rippling or something.
Yes, of course they will find some surgeon who will do it, but in my aesthetic feelings, I'm not confident with that, and I don't like the outcomes. And I think you should be honest to yourself and doing only things you want to see, and you doing things you like. And as I don't like it because I don't like the outcome and I don't like the results, I completely stopped. And if they wanted to say, okay, you will find someone else, but not me.
So, and about rippling, I want to ask about how do you think this implant, if they more hard, it could maybe theoretically less this rippling after operation, or in your experience it's not?
Hard question. The rippling is something also depending on the coverage of the implant.
Of course, yes.
But if we go for rippling, then we have, of course, an overview now from the reconstructive surgery, where the implant has been after subcutaneous mastectomy, and there you have those real differences between the implants, as there's been placed other implants beforehand. Now we go more or less to the B-lite implants, which means, of course, you can't promise that there's no rippling after reconstruction. It's not possible.
Of course, yes.
Because it's depending on also on the contraction of the soft tissue, the envelope, etc. We have the impression that there's a little bit of less rippling, although it's not eliminated in compared B-lite to other implants. Probably the microthane might be an idea, but in any case, what we see in reconstructive surgery after subcutaneous mastectomy, you almost have the risk of implants, and we do a lot of lipofillings after that.
Я на вебинаре.
Вообще не буду. Привет.
I want about ask you about microton, Mesmo, with B-lite implants. Who better candidate for a microton B-lite? Who better candidates for Mesmo B-lite? How do you explain for yourself or patient which different for you?
Mesmo is the first choice, must say, if it's the lighter implant. So if it's around under 400 or 350, then most of the cases it's Mesmo. If have, for example, implant replacements, and this is really particular. It's not that I'm against Motiva. I also work with Motiva, but I think this is a situation where you should think about putting Mesmo microthane B-lite implant. If you have, for example, Motiva, which is bottoming out in all the dimensions, and they want to have this removed because of the movements of the implants inside these oversized pockets they make, then I think it's good to have a microthane implant, because it really got stuck to this so-called minimized capsule, because in fact we really see that the Motiva don't make a capsule, a strong capsule at all. So you have to suture the capsule, and then you bring the microthane covered implant in, and this will stay and stabilize itself. So I think this is one of the most important situations where I really switch to the B-lite microthane covered implants. Mesmo, as I said, in most of the cases, if they're around 300, 350, I take the Mesmo.
Okay, it's clear. It's maybe the same. I'm agree with your position. So you know, for me, interesting of this implant, because I think it's next step of evolution implants. Yes, right. Because Polytech, it's try to do more safe, more better implant. What do you think? Which next very big problem if implant we need to discuss with Polytech to use? For example, I think we need to implant which could change volume. For example, patient want to 300, but maybe sometime 400. It could be it could be next generation of implant which could be a change of volume, for example.
So
And we need to speak. We need to speak with Polytech and tell them we need to try to do explant. Yes,
Okay.
please explain. Agnes, maybe you want to tell us about which new could be.
If you allow me, I have 5 comments. I wrote it on the paper, and I think
Okay.
Pavel could also translate maybe in Ukrainian, because I think it's important. Why? Because I think that I work now with more than 20 countries which are really actively selling B-lite. So all, I'm sorry, shit is coming to me, to those ears, to emails and all the things. So I think that I have a good reason why I could say some few comments. Could you, Pavel, translate maybe with word shit?
Це каже, що у неї є 5 коментарів стосовно нашої сьогоднішньої зустрічі, тому що у неї зараз 11 countries.
20, more than 20.
Oh,
I
sorry.
think be like 20, yes, it's 20, because some are not registered yet.
Going to under expertise. Вона каже, що у неї 20 країн, які активно використовують B-lite, і, звичайно, вся кака, яка лізе від пластичних хірургів з питаннями чи з незадоволенням, проходить через неї. Тому у неї є своя гарна думка і експертиза з цього приводу.
So first of all, I have the new B-lite sample in my hands. Why I say new? Because we change a little bit the softness of the B-lite, and I'm very unfortunately during those difficult times we are having lack of implants. We are not being able to send new samples, and I know that many Ukrainian doctors also ask for samples. I don't know, Thomas, how are you with the samples? But however, you know, this edge of the implant is much softer. It's not so visible maybe on the screen, but if you it's really much. So we worked on the softness of the gel, and if we speak about the next generation of the B-lite, I think that we will keep the lightness of the implant, but it will be much softer in our next generation of the B-lite, which is under the, of course, approvals, and this will take some time because this is not anymore so easy. So Pavel, can you maybe translate?
Скаже, що у неї в руках зараз новий семпл B-lite. І чому вона каже новий? Тому що у нього більш м'якіші, не такі кутуваті края, і якщо буде B-lite, слідуючий B-lite, то він буде набагато ніжніший, м'якіший, ніж минулий.
And if we speak about the rupture, I heard about this one finger thing. So if I would have here any implant, any company implant, even our Mesmo Sublime line, I can take my finger and I can rupture any implant. Why? It's not because we are not we have not passed quality or this implant is defective. No, because if we speak about that I can stretch it, I don't have the power now to stretch it because it's usually tested between 2 metal plates, you know, and then we stretch while it ruptures. but now it's impossible. But if you press on with one finger and put all the force on the small area, you know, you are doing, your force is extremely big. So that is why we recommend to do it, you know, with the rotation movements with 2 fingers, never to put through.
And this finger.
or with your, yeah, this is also good from you. Yeah, so but this is our kind recommendation, not because we use the different shells, but just because the shell, the gel inside of this implant is more cohesive, as you both also said. Yes, so this is not so deformable, how to say. So
Через те, що гель в B-lite більш когезивний, ми завжди рекомендуємо використовувати такі поступальні рухи руками або пальцями, або використовувати, як Денис Олександрович каже, великий палець, для того, щоб не давати велике навантаження в одну маленьку точку. Якщо ви використовуєте один палець, це створює велике напруження на одну маленьку точку. Більш когезивність гелю це може привести до такої події. А розтягувати B-lite можна в 900 разів, 900%.
Yeah, to 850%.
Окей, 8,5 разів його може розтягнути. Тому...
Let's not lie. It's not 900, it's 850.
Yeah.
Yes. So the next about Keller funnel and our poly sleeve. So our poly sleeve was in fact designed to turn microtane surface into smooth surface and to ease its insertion. So of course, this is not a Keller funnel analog. I'm sorry about this. I apologize that this was not the case for us, but we just put it inside to wrap inside the implant, so microtane becomes more slippery to insert. So this is unfortunate. Unfortunate. Yes, this cannot be used as Keller funnel, and.
Wait, I'm not a perfect translator, so give me a chance to translate it step by step. Той карман, рукав, який ми надаємо з імплантами, він був в оригіналі розроблений для того, щоб можна було його використовувати з мікротанами, для того, щоб мікротан можна було обертати. Тому його складно використовувати з іншими імплантами. Бо Томас Раппл казав, що йому важко використовувати ці рукава. Це для мікротану.
Yes. And if we speak about Mesmo ideal, I would say indication and maybe the first patients for Mesmo round implant, if we all would like to promote this texture, I think this would definitely be mastopexy augmentation patient. Or the patient who had before the implants and now she needs to use, you need to because I'm hearing a lot of good feedback after this surgery, exactly because why round, first of all, Mesmo round is absolutely safe, even if it will do some slight rotation, nobody will see it because this, and plus the mastopexy augmentation is already stating that we have enough tissue coverage, so this is absolutely safe. And then this is your like the first step and the first surgery. Maybe Thomas could add some more comments about his first patients, and this is, I think, safe step to start.
Yes. So this is definitely a good comment, and I can only underline this because mastopexy patients almost have damaged skin, and that's why they have this ptosis. And to do augmentation mastopexy, as we know, this is one of the most challenging breast operation we have, just to bring it into the best possible outcome. Therefore, I completely agree that the Mesmo with the lower pressure on the lower pole and the stable outcome, this is quite a good option. And even also saying round, because you're building on a round platform, some building, and it will be stabilized for a long time and has a really nice outcome. So for mastopexy, yes, definitely 100% agree.
And plus, this is very safe also incision. You do not do it through 2 centimeters definitely. So you can never put finger inside because you have no incision space. This is not even a joke, really. I'm just gathering the information from our from stage as well, and they are suggesting. And the last one, if we speak about capsula, because I remember, I'm sorry, I'm coming from my old school was in Allergan back in time in 2008. And I remember that all the companies at that time were fighting about pore size and pore depth. Now all the breast companies are fighting like crazy about capsula. And we have fantastic author of fantastic clinical paper, Barbara Cogley. And she, in fact, did now research with 5 different surface expanders. I'm sure that Pavel is doing translation into Ukrainian for this paper as well. So Mesmo and microtane surface showed the best balanced capsule in terms of both, because without capsule, we don't have predictability. So this is only last comment. I'm sorry that I interrupted your discussion because you are professional doctors and all, but just I'm having so many communications with our good speakers. I wanted just to add this. So Pavel,
was a perfect input.
thank you very much.
Thank you.
Thank you for your input, Agnes. And we also have a couple of questions for both speakers. So the question from Konstantin from Odessa. How do you get the implants symmetrical when installing the implants? We know that they are not behaving or acting that actively as non-B-lite implants, and you should put implant a little bit higher than the normal implant. But which methods concretely do you use to assure that there is a symmetrical result?
In fact, it's the pre-op measurements you're taking. So of course the external notch to nipple, and also almost to the belly button to the inframammary fold incision, so that you have really the same incision height. But of course, taken into account if they are quite symmetrically. Because in any case, if you have a higher inframammary fold on the other side and in the other, on the right side and then the left side, and they put just the incision 1 centimeter accurately under the inframammary fold, you put the implants in, and you didn't mention or measure in front that you have to bring the inframammary fold incision in the same position, then you might end up with some problems like different nipple positioning, different nipple viewing, and I think this is measurement beforehand is the most important and the cue for that.
And again, add to this, but we fixate new inframammary fold for not resorbable suture. For fixate this implant for one level.
Yeah, we fixate it, but not with non-resorbable. We use we use PDS, so the long-term resorbable. Yes.
We're preferring Etibond,
Okay.
not resorbable.
Yeah. Well.
Okay, and then there is also another question which is commonly asked on the B-lite seminars. So the really skinny patients are constantly complaining that the edges of the implant are palpable. How do you deal with it?
I think that there are now, as Agnese was showing us, the new implants which come on the market, they will solve this problem. But I see it with all the other implants as well, that you have skinny patients that you can touch and see the edges. So it's almost also the question about the footprint of the implant compared to the thorax width of the patient. And if the footprint is too wide for the patient, then in any case, you will feel and see the implant. So you have to narrow the footprint of the implant, and it won't be that palpable here in this area. So it's almost, of course, the question about the wish of the size of the patient and what is possible to get into this pocket to create a nice outcome.
What about you, Denise?
We speak about this patient before operation and try to explain all this maybe future problem and explain what it could be a life of feeling if it's possible. But yes, we need to speak about this problem. I'm preferring to explain this problem before operation and try to use small maybe implant than patient want, because it's for example it could be not aesthetic view or something like this.
Okay, so thank you. Another question: how often do you B-lite with one mastopexy with simultaneous augmentation?
How often?
Yeah.
I think nowadays it's like I'm getting older, my patients are getting older. That's why I really have around 50% and almost think when I'm sitting in the office, oh God, I would love to have a primary augmentation again. So it's becoming more and more, actually speaking.
Before this meeting, I decided to calculate how many implants B-lite we use it, and it was 43 cases, about maybe a few cases of with some kind of mastopexy, and all cases just primary case with big implants. It's it's not often. It's about maybe sometimes we're using this amount of months, but this is for these 4 years we're using only 43 cases.
Mm-hmm.
So you're younger, so wait till you get my age, then you will have also the mastopexy augmentation.
Okay, so one question from my side then. You Thomas, you started your presentation with the idea that in the end the communication with the patient comes to the point where it's all about the price, and basically it's all about how you sell them. So what is this that you are using to propose, to ensure, to lead the patients to the need of using of a B-lite usage, or you are just saying that you're working only with B-lites and that's all? If you don't want a B-lite, just go.
No. I let them the choice which one they want to have, but nevertheless, bring it in. It's like if you're buying a Louis Vuitton bag or something. So it's a question about luxury. It's also something, it's new, it's glamorous, it's luxury, it's good for sportive. And of course, the technology is safe, which in my opinion is the most important one. And till several years ago, almost saying, okay, now we have 5 years of experience, so we can say, blah, blah. But now, as we're working with B-lite since 7 years, almost 8 nearly, so we really have a good overview of the past, and we can say that there's really a safe implant on the market, which has all the benefits which were mentioned. And if you say, okay, we have all those long time period backwards, which, for example, Motiva doesn't have because they're not that long on the market as we are. So I think this is something to convince the patient in terms of safety. Also, it is the support of the company if you have some problems, etc. This is also something which is important for the patients, that they know, okay, they have some guarantee on the implants, and this is also convincing for them.
Dennis?
For me, it's too very interesting, but it's something new. But if my patient go into consultation and very want to some new, I'm trying to understand if she clear understand what for this new implant. If she doesn't care, she just want a new, and at all, it doesn't matter that this price is higher. I'm trying to explain, but this implant for my practice using for only for big, maybe big amount, big volume.
Mm-hmm.
If patient want to standard volume, I'm recommended not to use this implant for my practice.
Mm-hmm. But probably after today's seminar. Another question here, once again concerning the skinny patients. Thomas, do you use lipofilling with B-lite for the skinny patients?
Normally, I don't find enough fat for lipofillings for the skinny.
Yes.
That's the main problem. So
we need to find, yes.
Yeah. If there are sometimes we use it if they're normal weighted patients, but only if they say, okay, we want to have some fat removed in this or that side. Then I say, okay, before we throw it away, let's put a smaller implant and work with the lipofilling around the implant. But I don't have that many of those composite breast augmentations because I think if we have the opportunity to work with anatomical shaped implants, we have all those possibilities. And so I don't think there's really a need for those camouflage implants in Europe like it is in the US, where they're not used to work with anatomical shaped implants.
Okay.
Just one more. It's very difficult to find the volume of fat, but sometimes we use it for make more symmetrical. We use lipofilling for more symmetrical, and some camouflage if we just see some small some asymmetrical problem. We could not prefer. We prefer it to do lipofilling, not different implant, not different volume of implant.
Thank you. Agnese?
Yes, I just wanted to add about the weight and big size and small size, because while I was speaking, I was also holding all the time this B-lite implant in my hands, and it's only 320 ml. But after a while I was speaking, I was also starting to feel its weight. So let's not underestimate even 50 ml difference if we speak that I will carry those implants, a lot of years. So each milliliter, I think each gram, is very, important. So this was my comment, because it was funny. I was holding it and it was becoming heavier. I was, oh my God, what's going on this? So this was my last comment about.
Anything anyone would like to add to our meeting today?
Maybe some women.
Only thank you.
Thank you. Okay.
Only thank you for invitation to this meeting, and we would like to discuss some new if you have something.
Okay, great. Of course we have something. We always have something to discuss.
I have a lot of funny videos to show on the next webinar. Thomas knows.
So then I would like to thank both of our speakers for today, Thomas Rappel and Denis Yurchenko. Thank you for attending our seminars. Thank you for making it happen and for giving us nice tricks and tips on how to use B-lite and when to use B-lite. I hope it was of big importance for our audience, and I will once again remind for the whole audience that you will be able to find the recording of this webinar online under the link which I posted at the beginning of the chat. Ще раз хочу подякувати нашим сьогоднішнім спікерам Томасу Раплу та Денису Олександровичу Юрченка за участь в цьому семінарі, за те, що вони погодилися в ньому прийняти участь, за те, що ділилися своїми знаннями та практикою, і сподіваюся, ви для себе змогли почерпнути корисні підказки. Нагадаю, що запис цього семінару буде на нашому сайті. Через пару днів нам треба його ще трошки доперекладати потім, щоб субтитри були якісні, бо YouTube робить жахливі субтитри на пластичну хірургію. І тоді, якщо ви хочете передивитися, ви зможете його передивитися. Окремо дякую Агнес за підтримку цього проєкту. Thank you all once again, and hope to see you soon on the next Poetry Talk events.
Thank you very much. Have a safe Christmas year, and hope to see you in person next year. Bye-bye. Thank you, man.
Thank you.
Bye-bye.